Okay, here we are in Bio 1221, and we're going to start talking today a little bit about articulations and movement. When I talk about articulations is just another word for joint. Okay, obviously everybody should know what movement is, but articulations means a joint. So what type of joints do we have? First of all, we could classify joints a number of different ways. The first way we could classify it is by what's called a functional classification, which is based upon how much movement that particular joint has. The first type of functional classification we have is called synarthrosis. So synarthrosis, syn means together, okay? Arthro means joint, so osis means condition. So what happens is synarthrosis means that the joint is basically immovable. There's no motion that occurs at the joint. Two bones are connected together, but there's really no motion at that point, at that joint. Amphiarthrosis means a joint that is slightly movable. It's not as freely movable as most of the joints that we normally typically associate with being a joint, but it's only slightly movable. And there are small joints in the wrist and things like that. They are basically an amphiarthrosis, which are only very minimally movable. The joints that we normally think of when we think of a typical joint is a diarthrosis or a diarthrotic joint, which is basically a freely movable joint. We're talking about the finger joints, the elbow joint, the shoulder joint, the hip joint, the knee joint, the ankle joint, very freely movable. These are all what we call synovial joints. And I'll get into what a synovial joint actually means in a little bit, what we do mean by a synovial joint. And basically these are joints that have a synovial cavity, but we'll talk about that in a second. And while the diarthrosis is a freely movable joint, there's lots of different shapes, and we'll talk about some of the different shapes. Some of them are sliding, some of them are ball and socket, some of them are hinge, and we'll talk about those individual shapes in just a couple of minutes here. So this is a functional classification. Synarthrosis, a joint that's immovable. Okay, let me highlight it. And amphiarthrosis, slightly movable, and diarthrosis is a freely movable joint. We could also talk about joints in regards to how they're structured, how they're put together, what really makes that joint up. The first type of joint we have is what's called a synostosis. This is where bone is connected to bone, okay? Where there's something that connects. Ostos means bone, okay? So synostosis, together of bone. So bone is connected to bone, and that's called a synostosis, okay? Fibrous type of a joint is a joint that's held together by fibrous connective tissue, which we all know from our first section in the lab is sort of a dense connective tissue. There's no synovial cavity, there's no cavity inside the joint, and basically typical examples of a fibrous joint would be a suture joint. These are the little joints that we have between all of the cranial bones. A syndesmosis, we saw a syndesmosis between the tibia and the fibula, where basically ligament holds the tibia and the fibula together. And a third one, which we have here, is called a gymphosis. Now this isn't very typically used a whole lot, and basically that's how the teeth fit in the sockets in the alveolar process of the maxilla and the mandible. This is a gymphosis, where we have a socket and you have a peg that fits inside of a socket, and it's held together by fibrous ligamentous structures that holds that peg in that socket. The next type of structural classification we have is a cartilagenous joint. Cartilagenous is just what it says. The joint's held together by cartilage, okay? So there's no synovial cavity in there, and I keep on mentioning synovial cavity. We'll talk a little bit more about this in a minute. Typical example of this is a synchondrosis, as well as a symphysis. We talked about the pubic symphysis, where the pubic bone in the front of the pelvis comes together and is held together anteriorly by that small little disc of cartilage, okay? And a synchondrosis may also be something like where the rib is connected to the sternum. It's not connected by bone to the sternum, the rib bone connected to the sternum bone, but basically by a piece of cartilage, or that chondral cartilage. The joint that really we think about when we talk most about joints is called a synovial joint. And a synovial joint has a special form in which it's made. What happens is around the outside of that joint, it's held together by what we call a capsule. A capsule. Basically, that's ligament and dense connective tissue that holds the two bones together, as well as inside this capsule are supporting ligaments, either intercapsular within the capsule, capsular, which are part of the capsule, or extracapsular, which are on the outside the capsule. We'll talk about that before. But the biggest thing that really classifies or characterizes a synovial joint is they have a synovial cavity. There's a cavity within that joint which is filled with a fluid which we call, guess what? Synovial fluid. And that's what we have. We'll talk a little bit more about synovial classification in just a minute. Let's talk about some of those joints individually. Let's talk about the fibrous joint. Okay, we didn't talk too much about the synorthosis because that's really not or synostosis, which is really not a big factor here. But let's talk about a fibrous joint. And again, we talk about the sutures of the skull. These are the bones of the skull that actually come together, and we see all those little jaggedy things. When we looked at the skull before, we see the bones of the skull coming together. Between all those little jagged edges are basically a thin layer of dense connective tissue that's between those. So if we look at this suture joint right up in here, that's what the suture would look like, and what really holds together that is a very thin layer of dense fibrous connective tissue. Eventually, as we get older, this suture joint starts to actually fuse, and we lose a lot of that dense connective tissue. At that point, it does become a synostosis as we get more towards being adult. Okay, that's called a suture joint. Syndesmosis we talked about before, and what happens is, this is the typical example of what we have with syndesmosis. While this tight gap that we find in a suture is very, very small, the syndesmosis actually is a little bit looser. It allows a little bit of movement, okay, between that. Now, if we look at this anatomical specimen over here, and this would be the fibula at this area, and here would be the tibia. Here's the ankle joint sitting right in here. Let me get another pointer here. The ankle joint would be sitting right in here like this. So here's the tibia up in here. Here's the fibula sitting over here. And what really holds the fibula and the tibia together is a ligament right here. That's the tibiofibular ligament. This one would be the anterior inferior tibiofibular, because in the front it's in the lower portion. We also have an anterior superior tibiofibular ligament, which is where the head of the fibula, the top of the fibula, meets the tibia, very close to where the femur is. Okay, there is slight bit of movement, and I could talk about that a lot. If we remember just a little bit of just to give you a little idea about that, if we remember this bone right here, we know is called the talus. It's a talus that fits inside that upside down joint called a mortise. Remember that as an extra credit question, a mortise. What happens is the talus is wider anteriorly and narrower in the back. So when I dorsiflex my foot up, when the foot comes up, when the toes come up, this wider portion of the talus fits between the fibula and this fibular malleolus, which is right here, and the tibial malleolus right here. So I have to have a little bit of a spread at that point to allow a little bit of a buffering, because that wider portion of the talus fits inside that gap, that mortise joint. If you ever hear of somebody who has a high ankle sprain, basically this right here is the ligament that's involved with that high ankle sprain, that anterior tibiofibular ligament, anterior inferior tibiofibular ligament. Again, there's a proximal, and a distal one. Okay, and that's what we see with the tibiofibular ligament. And there's a slight amount, it's connective. It's ligament that holds the two bones together. The gum fossa we talked about is a dentoalveolar joint, which are basically the teeth. I talked about a peg fitting into a socket, a cone-shaped peg fitting into that socket in that alveolar process of the mandible and the maxilla, and that's what we call a gum fossa. That's a gum fossa. This is again looking at suture joints here. In a skull, you can see all these little suture joints. Again, this suture joint actually eventually becomes a synostosis with time. I'm not good at drawing these little lines with my mouse, but that's what we see there. Okay, so let's move on. Synchondrosis, and basically a synchondrosis is where we, as a connection with hyaline cartilage. Typical example is the epiphyseal plate, but more importantly that we have existing to adult is the area of the rib to the sternum. Okay, so if we look at a chest, well, this would be the area of the epiphysis, right, or epiphyseal plate right here, which is a specialized cartilage, but I'm not even considering that so much right now. But when I look at the chest, the thoracic cavity, here's my rib right here, here's my rib, and this whole area right in here on both sides is all cartilage, and basically that creates a synchondrosis. Okay, a symphysis. Symphysis is where the ends of the bones are covered with hyaline cartilage, and what happens, there's no motion at all. Okay, there's a flat disc of fibrocartilage that connects the bone ends, and again right here is where I had that pubic symphysis. So this would be the pubis right here. Here's the pubis on this side, and right in the middle of this area right here is a disc of cartilage that holds it together, and that'd be called a pubic symphysis. So a symphysis is that disc of cartilage that holds two bones together, and that's what we see there. Okay. Synovial joints. Now this is the fun part, and this is where we get into some really more interesting type of arrangements of a joint. Well, synovial joint signifies that it has what's called a synovial cavity, which means that between the two ends of the opposing bone surfaces, there is a space, a potential space, which is basically filled with fluid. This allows that joint to be freely movable. That fluid, which is called, obviously, synovial fluid, is slippery and allows the end where the articular cartilage at the end of the bone is able to slide against the bone on the opposite side, because this slippery fluid, that synovial fluid, allows the cartilage to slide very easily over over the other. So the bone ends in a synovial joint are covered with hyaline cartilage, which we know as that articular cartilage. Again, they're smooth. The cartilage is both smooth and slippery. It doesn't allow binding. There's a separation between both ends of the articular cartilage, and with the smooth articular cartilage as well as the synovial fluid, it reduces friction. One of the problems that we get in arthritis, osteoarthritis, is that articular cartilage gets worn away, and as a result, instead of being a smooth, slippery surface, it becomes a rough, grindy articular surface, and that's what we get, that grindiness that we get with osteoarthritis. Okay. Again, that we talked about that, so we don't have to talk about that again. Okay, that's the same thing we had. Let's just look at another joint here. Here's the end of a bone. There's that endosteal canal. Ooh, that's neat. Here's the cortical bone right here. This would be diaphyseal bone. We get down to the metaphysis would be here. Epiphysis, that would be the area of where the growth plate would have been. And this area out here, this gray area on the outside, would be the capsule, and that would be the ligament that would support the capsule. This green tissue right in here would be the synovium, and the gray at the end of the bone would be the articular cartilage. And then this space in between in here would be called the synovial cavity, and that's filled with a little bit of synovial fluid. This is that cadaveric cross section, where this is the head of the humerus. This would be the area of the glenoid fossa of the scapula. See how it's important to remember all those names of bones? And this is the bone, that's all that cancellous bone here, cortical bone here, very thin cortical shell. This little white line here is basically the articular cartilage. The synovium would be from about here to about here, and then from about here to up in here, and that's what produces the fluid that would fill this gap, and that gap here would be called the joint cavity, or the synovial cavity, which is filled not with a lot, but just a little thin layer of fluid. Okay, and that just lubricates and makes the surface of the joint very slippery, which allows that freedom of movement to occur. And that's an important thing about synovial joints. Again, when we lose that cartilage, we have a problem. When that synovium becomes inflamed, we have a problem. Or sometimes we have an injury, sometimes that joint swells, and that's called an effusion, E-F-F-U-S-I-O-N. So if I have a large swollen joint, sometimes that joint will collect with a lot of blood, as well as, because the inflammation will cause a lot more synovial fluid in there. That's when sometimes have, I had to go in and get my knee tapped because they had this effusion that was inside their joint, E-F-F-U-S-I-O-N. And that's what we see in what it would look like in a cadaver specimen. Okay. Now let me talk a little bit about the synovial fluid. Again, that synovial fluid is secreted by cells in the synovial membrane, and that fluid is very slippery. If you actually took it on your fingers, it would be very slippery-like. In fact, what happens is when people have arthritis, sometimes what they will actually do is they will inject into the joint something almost like an oily substance that will be sort of like replace that synovial fluid, the Synvisc or Hyalgin. There's a number of different names for it, and basically what that does, it lubricates that joint surface when the joint surface needs a little bit more oil inside there. Most synovial fluid is very viscous, which means that if you take your fingers and you put it between your fingers and pull your fingers apart, there'll be like a little string that'll form of that because of the viscosity of the material. It's usually clear and a pale yellow. Okay, you'll be able to almost see through it in a normal synovial fluid in pale yellow. Inside that synovial fluid, there's something, you don't have to remember this, I wouldn't ask you about that, but there's hyaluronic acid. And what happens is this is secreted by fibroblast-like cells, again, going back to our good old friend, the fibroblast, which is going to come in and haunt us multiple times. And what it does, it prevents that synovial fluid from clumping up. It keeps it
thinned out, not thinned out really, but it keeps it so it doesn't form in like the big clumps inside the joint. Okay. Also inside that synovial fluid are phagocytes. Phago means to eat, cyte means to cell, and basically these are like white blood cells or macrophages that will go in that eat up debris and microbes that actually get inside the joint. The purpose of that synovial fluid, then, we know, is to provide that lubricating fluid to be a friction reducer. Also, what happens is, remember we talked about the end of the bone is covered by cartilage. How does the cartilage get to nutrition? Well, the good thing about it is we know cartilage has very few cells. There's not a whole lot of cells in there, and most of it's matrix. Okay, and we know that from seeing it on the microscope, underneath the microscope earlier in the year. So hopefully all this stuff is coming back to haunt you. What happens is inside that cartilage are small little, if you remember looking at it, it wasn't perfectly smooth. There were small little clefts inside that cartilage. So when the joint moves, it actually takes some of that synovial fluid, which has nutrients, and actually sort of like forces it inside that cartilage to allow that cartilage to become more abundant in nutrients for the survival of the cartilage. If you've ever been in a cast and the joint's not moved when you come out of the cast, joint's actually very dry. Okay, it's not totally dry, but it's drier than it should be, and as a result, it takes a while for some of that motion and that slipperiness to come back. Okay, and besides that, it removes waste from the chondrocytes of the articular cartilage, because obviously the cells, when they utilize nutrients, what's the end product? Everything ends up in waste. So we have to get rid of that, and some of the macrophages in there will remove that as well. Okay, this is just a little image of what we'd see looking at the synovial fluid. This is synovial fluid that would come out from a normal individual, and you see how it's like a pale yellow and it's relatively clear. Here's a fluid that's a little bit more turbid. It's really not totally abnormal, but it's something, maybe the joint has some level of disease to it, but not bad. This would be an inflammatory synovial fluid here, and what happens is the inflammation. When we see something with inflammation, what it means is there's going to be a lot of white blood cells that will go to that area, and so it's an inflammatory response. And as a result, there we see the fluid becoming a lot more turbid, more difficult to see through. If you look here, you can see the little X's behind it. Here you can still see some. They're getting a little bit. We can't really see a whole lot here because there's a lot of particulate matter that's inside this fluid. This is septic, and all this clumpy stuff down here. Guess what that is? That's our good old friend pus. So septic. When I see the word septic, septic means infected with pus. So this is all clumps of pus that are all inside there, and obviously this is a hemorrhage that we see inside the synovial fluid at that point. It would be red. And sometimes what happens is when it breaks through the capsule, I know that sometimes when I've done a joint aspiration means the process of sticking a needle in and sucking it out, or an arthrocentesis, arthro joint centesis, surgical puncture with a needle to remove something. Sometimes when I had a hemorrhagic a tap, you'd look at the top and there'd be almost like a little bit of a glistening material, almost like when you look at some, like your grandmother's soup, there's like a shiny sheen on the top, and a lot of that's because of the fat from the capsule that may actually slip inside there, and it sort of like covers the top of that column of fluid. Okay, and there's the same thing that we talked about there. Let me just talk a little bit about these ligaments that we have in the joint. What do ligaments do? Now, I mentioned this very briefly before. Ligaments hold things together. Okay, so in other words, if I'm looking at how do I keep the talus up inside that ankle joint mortise with the tibia and the fibula, basically ligaments do that. They hold it together. They hold bone to bone, either sometimes within the capsule, sometimes part of the capsule, or sometimes outside the capsule. So they hold things together. What they do is they restrict the abnormal or excessive motion. If you've ever sprained an ankle and your foot goes in underneath you, your foot goes in underneath and turns inward underneath you, what happens is the ligaments on the outside become stretched or sometimes even ripped or ruptured. Okay, and as a result, the ligaments normally, if they're strong, they'll actually help to resist that motion. Also, because again the ligaments are all these parallel fibers, they're lined up in such an orientation and an angle to the bone to allow and guide normal motion. So in other words, they're not just put there haphazardly. They're there in a particular orientation, whether it be this way, whether it be this way, with those parallel fibers this way, but they're there to be able able to guide normal motion. Okay, what is a ligament? Well, basically we know it's dense connective tissue, and that dense connective tissue is nice and tight. They're, again, parallel fibers, many fibers, few cells, minimal matrix. Achilles tendon is probably one of the larger tendons in the body, if not the largest. And what happens is because it has few cells, that's a good thing, but it's also a bad thing. It's a good thing because it doesn't really require a whole lot of nutrients and oxygen to be able to survive. It's a bad thing when we injure it, because what happens is, how do we heal? By bringing in nutrients and oxygen. So therefore, and making those cells to replace themselves. And therefore, what happens when we're talking about healing time of ligament and tendon being quite long. Actually, I shouldn't have said a ligament for Achilles tendon. It's really a tendon, not a ligament. But it's the same type of a characteristic. Ligaments heal longer simply because they have few cells. Tendon, like the Achilles tendon, it takes a long time to heal because it has very few cells in it. Okay, so that's what happens in these accessory ligaments. Again, when I look at accessory ligaments, they could be extracapsular, capsular, intercapsular, exactly what they sound like. Extracapsular is on the outside of the capsule, such as the lateral collateral ligament of the knee. I could actually show you if I was there. I'm not there, and I don't have time to stop at everybody's house. But if you actually cross your legs, you feel on the outside of the knee, you'll feel like almost like a pencil-like cord on the lateral aspect of the knee, and that's called the lateral or fibular collateral ligament, which is outside the capsule. It's actually separated from the capsule by a bursa and a tendon or a muscle that runs right through the gap between the ligament on the outside and the capsule on the inside. Capsular means it's part of the capsule. The medial collateral ligament, which is on the medial side of the knee, is a very broad and very flat. Okay, and therefore it's part of the capsule. It's where that capsule actually becomes dense and firm, and that's called the medial collateral ligament at that point. Intracapsular is inside the capsule. It's sort of like a little misnomer, because what happens is synovial membrane covers that intracapsular ligament. And we talk about the anterior and the posterior cruciates. Cruciate means cross, and these are little cross ligaments that are inside. We talked about the intercondylar eminences that we saw, those little humps on the tibia that went to that condylar fossa on the back side of the femur. And basically what happens is that's where the anterior and posterior cruciate ligaments are, and they since they cross, are called cruciates. Cruciate means cross, and they're covered with synovium, but they're inside the joint capsule itself, and those are what we see with the cruciate ligaments. Okay, this is just looking at the knee, and again, this would be a cruciate ligament coming here. Here's a cruciate ligament. Here's the anterior cruciate here, posterior cruciate, and they're inside the knee capsule itself. Again, going for those intercondylar eminences, which would be here into that area, that condylar fossa, which is between the medial, and oops, there's the medial and the lateral femoral condyle. Okay. One other thing I want to mention before I get off of this are what are called articular discs or menisci. Okay, I showed this in the lab a little bit, and these are inside some but not all synovial joints. And if I look at the tibia, the top of the tibia is relatively flat. If I look at the glenoid fossa, it's only mildly concave, okay? And so as a result, when I have the humeral head, which is round, and when I have the femoral condyles, which are round, sitting on that flat joint, why don't they just slide back and forth? Well, what happens is a meniscus are actually fibrocartilage. They're pads of fibrocartilage between the articular surfaces. So I'm still going to have cartilage that covers articular cartilage that covers the femoral condyle here, and in the center of the gaps of the menisci, I'll also have articular cartilage. What happens is the articular cartilage is high on the outside and narrow on the inside. It creates a cup. Okay, it modifies the shape of the joint to allow for better congruity. So now these femoral condyles have a cup in which they sit that makes them a lot more stable. So in other words, this meniscus provides a cup surface like here, a cup surface like this. Actually, it would come down this way. There's no point in the middle. It comes down this way. Let me erase that. Get rid of that red stuff. Okay, let me draw a femoral condyle again. Femoral condyle, tibial, plateau. And if I look at that meniscus, it's going to be high around the whole periphery. It comes down to the center like that. And then the meniscus on this side will be high and the periphery all the way around and come down the center like that. It creates a more of a cup-shaped area for the femoral condyles to fit in. Okay, so also by doing that, it allows a better flow of that synovial fluid around the femoral condyles. So besides providing stability, provides and directs the synovial fluid better to keep that joint lubricated. Okay, and that's what this menisci do. If I look at a picture right here, this is the picture we showed before. Here's the cruciates. This would be the lateral meniscus over here. Let me use a different color. Here's the lateral meniscus on this side. Here's the medial meniscus on this side. And if you see, this is a good picture. There's articular cartilage is going to be sitting in there, and articular cartilage is going to be sitting right here. And obviously, this is articular cartilage here, and this is articular cartilage here. But you see how this meniscus sits around to create almost like a cup-shaped area to allow the femoral condyles to sit in a little bit better. It provides more stability to that area of the knee. This would be the lateral collateral ligament, and this gap right here, the capsule is going to come this way. There's actually a muscle which sits between, which is called the popliteus muscle, which sits in there, as well as the little bursa. And this medial collateral ligament on the medial side is actually part of the capsule itself. So that's what we have with the knee meniscus. They deepen it. Same thing with the shoulder. The shoulder has a meniscus. The glenoid fossa is deepened by a rim of cartilage that has a very similar configuration in a C, or almost like more of an oval-shaped area around that glenoid fossa in the scapula, to allow the head of the humerus to fit inside there, and that works out well.